Good afternoon, dear class. Since we'll be recording the session, I think there's really no real reason to wait anymore. I've waited 5 minutes, so we can get started. My name is Mr. Adeyemi, and I will be taking the first 2 weeks of this course. I'll be taking it through sessions on the normal and adapted cell. We'll try and also explain what happens when normal cells come under stress, become adapted, and the stressors are not removed afterwards, leading to cell injury. And what happens if the conditions don't change and the cell uses up all its resources? What happens is cell death. And what is the inflammatory process and repair process that happens when cells become injured? There's reversible cell injury, irreversible cell injury. So what happens within that framework of cell injury, and which helps us now look at a very important class of medicines: steroidal anti-inflammatory drugs and non-steroidal anti-inflammatory drugs. So let's get started. First and foremost, want to introduce us to the normal cell and why adaptations happen. Like I mentioned, the normal cell is the cell in its homeostatic environment. That's the normal cell. Can be heart muscle cell, can be a dendrite, can be different cells in different parts of the body, right? And so what happens is all of the cells of the body have their normal homeostatic conditions in which they function appropriately, optimally. Now, in the presence of stress or strain, and stresses can be stress, for example, when you're lifting weights, be a disease process as well, or could be exposure to toxin and strain, right? So both of these conditions can be exerted on the normal cell, leading to adaptation, right? And if adaptation is not corrected within a logical time frame, it could result in cell injury. And if the cell becomes injured to a certain extent, the cell may be irreversibly injured and go on to die. Okay, we'll look at how all of these mechanisms come together to lead on to what we have as disease processes. Feasible, right, in a disease process. So cellular adaptations like that we can find, right, include things like reversible changes in number, size, the phenotypic arrangement of the cell, that's the way the cell appears, right, or the way the cell grows in the presence of physical stress and strain, phenotypic manifestations, metabolic activity that the cell ought to carry out regularly, or other functions of the cell, right? So all those adaptations are reversible changes. They are all reversible changes. So they can be physiological. For example, if it's due to hormonal changes, for example, when during the normal growth of a human being from childhood to adolescence, hormonal changes happen. That's hormones that cause the body to grow and change in different ways that are characteristic for boys and for girls, in different ways happen. And these endogenous chemical mediators would either lead to like breast development, the growth of pubic hair, deepening of the voice in males, and of course, other phenotypic changes that happen at adolescence. The same thing as well, we can have pathological changes, which is response to stress, right? In the bid to escape injury. And both of these, whether physiologic or pathologic, right, can give rise to these types of the changes that we're looking at: hypertrophic changes, hyperplastic changes, atrophy, or metaplastic changes. Now we're going to look at how each are different from one another. So hypertrophy is commonly caused by mechanical triggers or trophic triggers. And an example is, for mechanical triggers, is stretch. For example, if you exercise, right? For trophic triggers, we have where you have the main change happening, right? So once you have the stimulus which comes in, it could be the stretch, like we said, or genetic receptors. It leads to signal transduction pathways, leading to induced protein synthesis, growth factors, and structural proteins kick in. The cell size increases. How? Through the increase of myofilaments that are developed in the cell and proteins per cell. Hence, those cells develop improved performance, but of course, they also develop bulkier proteins within their content, so they become bigger. This is a very, very important, cascade of events. Reason being that the hypertrophy that we see in cells undergoing this kind of adaptation cannot happen without the increased production of cellular proteins, the myofilaments, and other proteins within the cell, right, that lead to the improved performance of the cell, that you see when you start, for example, exercising, and then you find that you are already able to accommodate to a certain weight of dumbbells, then you move to another set of dumbbells. All of that is your cell, your muscle mass, both increasing in size and of course increasing in number as well. But first, we're looking at the increase in size, which happens. Now, there can be a possible switch as well in the contractile protein that is present within the cells, right? From the alpha myosin heavy chain to a beta myosin heavy chain, which has better ergonomical contractions, right? So both the increase in the types of protein in the protein within the cell and the type of protein, right, lead to that improved performance that is seen. The adaptations are not perfectly elastic, which means that it does not mean it doesn't matter that the muscles are so big. What is important is that the muscles are efficient. At a certain level, muscles become, the building more muscles does not contribute to better efficiency in the use of power, energy. Next, we talk about hypertrophy, right? Sorry. So an hypertrophy is an increase in the size in structural proteins and organelles, just as I described earlier on, resulting in increase in the size of the organ. We must also remember, when we're talking about hypertrophy, that cells have a limited ability to divide. Cells have a limited ability. The physiologic example of hypertrophy is enlargement and heart muscles in adults due to exercise, while the disease process or the pathologic process is enlargement of cardiac muscles due to hypertension or aortic valve disease. These are important examples, as you will see. So that is hypertrophy. Now let's talk about hyperplasia. And hyperplasia may occur with hypertrophy. For example, during pregnancy, right? You will notice that the gravid uterus, right, both expands in cell size and in cell number, right, to accommodate the rapidly developing fetus. Okay. And this also happens to a limited extent in the muscles as well, right? And they are due to similar stimuli, right? Cells, the requirement for hyperplasia to take place is that cells must be able to divide and regulate replication, right? So they can up-regulate or down-regulate replication, due to stimuli that is being received by the cell. Physiologic examples of hyperplasia include hormonal hyperplasia, like the proliferation of glandular epithelium of the female breast at puberty or during pregnancy. Another example of hyperplasia, a very important one, is compensatory hyperplasia. This happens when, due to disease process, a portion of resection is a surgical process of removing either dead or diseased tissue in the liver or any other place, right? But here we're speaking specifically about liver resection. So what happens when there is liver resection? There is activation of growth factors that leads to, mitotic activity in the liver and leading to restoration of liver mass within within about 36 hours, right? The liver is able to grow, divide fast, and grow, back its resected mass within just a couple of days. Now, there's also the disease process as well that can cause hyperplasia or hyperplastic transformations. Excessive hormonal or growth factor stimulation in a disease state, for example, in endometrial hyperplasia, resulting from imbalance between estrogen and progesterone, leading to abnormal menstrual bleeding. The next adaptation we want to talk about is atrophy. Atrophy is shrinkage in the size of the, right? The cell becomes vacuous, right? The cell in atrophy shrinks in its size by the loss of cell substance. Functions are diminished, but the cells are not dead, right? So the cell shrinks by eating up what some parts of its cellular proteins, right? And this can happen due to decreased workload, loss of innervation, for example, due to trauma to the upper hand. There have been situations where, individuals have lost the use of their hand through vascular complications, leading to loss of innervation, diminished blood supply. Inadequate nutrition is also an important process leading to atrophy, and it's also part of the entire milieu seen in starvation, right? There's also loss of endocrine stimulation, which happens at menopause, leading to reduction in, excuse me, leading to cells atrophying, right? And another part is aging as well. Senile atrophy is seen where brain cells in older adults, right, lose their contents, right, as a part of the aging process. It's an important disease process, and a lot of research is going into studying how that mechanism, turns on. There's also as a mechanism, right? As decrease in metabolic activity, happens, there's decreased protein synthesis.
I will start. So you guys do that here. I won't make you do that.
So for all intents and purposes, I'm going to mute everybody now. And if you want to ask a question, you can raise your hands and I'll unmute you. I hope that's clear. Thank you all. All right. So moving on, like I said, there's decreased protein synthesis once there's decreased metabolic activity. And this leads to increased protein degradation through the ubiquitin proteasome pathway. And this is very common in an inflammatory process called cancer cachexia, right? Atrophy is accompanied by autophagy, that's starved cells eating its own components in an attempt to find nutrients and survive. We've seen 3 different adaptations so far, right? The 4th one we're looking at is metaplasia. It's a reversible change in which one adult cell type, an epithelial or mesenchymal, this is where it's commonly seen, right? Epithelial cells being replaced by a mesenchymal cell, or mesenchymal being replaced by an epithelial cell. And that usually happens in, for example, smoking adults, right? You can find genetic reprogramming of their stem cell. You can find right? You can find a transmutation of those cell types as well. Okay, so for example, I was talking about habitual smokers, right? The normal columnar cells in the right are replaced by squamous epithelium, leading to loss of mucus secretion. This is why you find and loss of ciliary clearance of particulate matter as well. This is why you find that people who smoke a lot tend to clear they always put a lot of effort in. Sorry, I hope it's better now. Okay. So let me come back again. I recall that, oh, thank you. I recall that you must have lost me when I was talking about the kind of transformation that happens in respiratory epithelium. So what I meant is, for habitual smokers, what should line the throat really is adult columnar cells, which are ciliated. But because of the assault of smoking and to adapt to the new condition that the columnar cells are experiencing, those adult columnar cells adapt and change to squamous epithelium. Squamous epithelium is similar to what we have on the skin, right? What we have on our skin outside is squamous epithelium. It's more rugged. It can withstand more rigorous conditions, right? So the skin, the layer of ciliated columnar cells in the throat begins to change, transmutate to this same type of columnar to this adult squamous epithelium, right? But when that change happens, it loses the ability to secrete mucus and also loses the cilia that helps clear particulate matter on in the throat. Okay. So I also mentioned that if the influence, for example, the smoking continues and persists, it may increase the risk for malignant transformation of epithelium. That malignant transformation of epithelium is a cancer process. Okay, that's the process where the cells become metaplastic and then they become dysregulated, leading to a primary tumor or a cancer process where those cells migrate to other areas and form other tumors that impinge on other organs elsewhere, right? Now, important to note that for gastric epithelium, right, in chronic gastric reflux or gastritis, what happens is the opposite. It is a squamous cell that are usually exposed to the acid cell that change to columnar cells. They are not ciliated in this case. They change from squamous cells to columnar cells to kind of which are more readily the columnar cells are they readily get hurt and heal better, right, compared to squamous cells. So that's an adaptation in that's a fourth adaptation that we are meant to look at. So let's quickly take a quiz just to be sure everyone is on board at this time. So you should see the quiz on your screen right now. Please attempt it. Just 2 minutes. Let's quickly look at the quiz. The quiz is showing up on your screen right now. If you can't see the quiz, let me know. Just put that in the chat area or send me a chat or just raise your hands, okay? Yes, find that. Unmute. What's going on?
So I can't see this quiz. I can only select summarize with the quiz.
Hold on. Let me see if there's a reason why you're not seeing the quiz. Can you log out of the room and log back in? Because it's showing me that everyone is seeing the quiz right now. So please, if you can't see the quiz, log out and log back in. You should be able to see the quiz. So far, we have less than 50% of the responses. I'm going to close the quiz soon, So please respond now. Okay, so I think you can see the correct answers. For the first question, the correct answer is there is a genetic reprogramming of stem cells without modification of adult differentiated cells. And then for question number 2, so all of them were single choice, right? I think some people were trying to answer more than once. At puberty, the glandular epithelium changes, hormonal hyperplasia, correct, which we said is physiological, right? Thank you. So let's go to the next. Someone's hands up. Uriri.
Yes, sir. Good afternoon, sir.
Yes,
Sir, there's one of my classmates that she's unable to join the class because she's having issues with her network and the Zoom app. So she's here listening with me.
Okay.
Thank you, sir.
All right. Thanks for being gracious. Yes.
Sir, I wanted to ask for that number one, because if the stem cells are modified, doesn't that produce like different differentiated cells?
I can barely hear you.
Okay, can you hear me, sir?
Okay, I can hear you now.
Okay, sir, I was saying that if the stem cells are modified, doesn't it mean that new differentiated cells are produced? So meaning that differentiated cells are also modified. Because the stem cells that will give you differentiated cells. Because that number
So your logic is
is
correct.
questions. I'm just a bit confused.
Okay, so your logic is correct, but the way it's applied here is that, so those, like I said, we have adult cells that are transmuted to adult ciliated columnar cells transmuted to adult squamous cells, right? Hello? Hello? Can you guys hear me?
Oh, yes, I can hear you.
Hello?
Yes, I can hear you.
Okay. So I said that the logic is correct. But remember that we said that they are replaced by adult cells, right? So what it means is it's not as if the cells there are eroded and new cells grow out. It's that the adult cells, as they are being replaced, they're supposed to be replaced by adult columnar, ciliated adult columnar cells, or rather they're replaced by adult squamous.
Yes, sir.
Does that make sense?
Yes, sir.
Right. So rather than have the cells that are, that are replacing those adult columnar cells being, that cells that are being differentiated as ciliated columnar cells, right? They rather become adult column. They are still those, the stem cells are still columnar stem cells, but they differentiate, rather than differentiating into ciliated columnar cells, they differentiate into squamous cells without cilia. I hope that's clear now.
Yeah.
All right, thank you. So let's quickly go to the next part of this class, where we'll talk. So that's that about cellular adaptation. Cellular adaptation can be pathological, can also be physiological. And as much as it's either pathological or physiological, there can be 4 types as well. There's hypertrophy, hyperplasia, atrophy, and metaplasia. And the one that often leads to cancer growth is, or cancer process, right, is metaplasia. And you can see from the name, it's similar to metaplastic, which is commonly used to describe cancer cells. So now if there is, continuous pressure, stress, or strain, maybe the hypertension is uncontrolled, what happens to the patient, right? There can be cellular injury. The cardiac cell can become injured. So the cell injury occurs when the cells are stressed so severely that they are no longer able to adapt, right? Or they're exposed to inherently damaging agents like radiation, or they suffer from intrinsic abnormalities, for example, DNA damage during cell division, right? So there can be reversible cell injury where functional and morphological changes are reversible if the damaging stimulus is removed, but there can also be irreversible damage leading to cell death, okay? And most of the process that leads to cell death differ, that they are different in both the way the cells appear, in the mechanisms that lead to the cell death, and in the roles they play in disease and physiology. We're going to look at it quickly. So here we have the normal cell in homeostasis, right? Under increased demand, stress or strain, will begin to adapt using any of those 4 methods. Like we said, the method it uses in adaptation is dependent on the type of cell it is. If it's able to rapidly divide, evidently it will undergo hyperplasia. But if it is not a cell that rapidly divides, then it might undergo hypertrophy if it can stretch, or if it can become larger, right? And if it's a cell that maybe has suffered disuse or loss of nutrition, then it can undergo atrophy. And if it's a cell that can be replaced by another cell type, then it can undergo metaplasia, right? And when that happens, right, if you remove the stimulus, then it goes back to the normal cell. But if you don't remove that stimulus, it goes on to become injured. Or if that's that stimulus that acts on that normal cell is inherently injurious, for example, radiation cells, radiation, a cell is exposed to radiation, it becomes injured directly. The cells can't even adapt to that, right? The cells become injured immediately. Now, when that happens, when this premise of cell injury happens, there are two things involved, right? It can become reversibly injured, which means that cell is able to, at some point, recover. If you remove this injurious stimuli, it's able to recover and maintain some sense of function, or it goes beyond the point of reversibility. That's the point of irreversibility, and becomes a necrotic cell. Now, remember that we talked about injurious stimulus earlier on. If an injurious stimulus happens to a normal cell, the cell becomes injured, but ultimately, because of the nature of injury, that cell will undergo apoptosis and die. Subcellular alterations are neither here nor there, but they happen both in reversible and irreversible injury. And it's important to note that regardless of what may have happened during cell injury, right, the nature of that injury will determine if it is reversible or if it is irreversible. We're going to see a couple of examples shortly, right? Reversible cell injury can still have this kind of features. Some of the morphological or the broad cell changes can include cell swelling, fatty changes, plasma membrane blebbing. That's the plasma membrane swells, and there's also loss of microvilli, mitochondrial swelling, dilation of the ER and eosinophilic clumping as well. Now, these can be features. When you see these features and no more, we can still say it's reversible cell injury, right? But when the cell happens to have the same changes that happen in necrosis, for example, when there's marked eosinophilia, that there is marked clumping of, those tiny, the endoplasmic reticulum is the rough endoplasmic reticulum is covered by some tiny grainy particles. If you recall from your biology, and of course, some of the revisions you had in 100 level, right? Now, when those particles are lost from the rough endoplasmic reticulum, then you begin to have, irreversible damage at that point, right? There's increased eosinophilia, there's nucleus shrinkage. That's the nucleus becomes smaller, right? It loses its particles, it loses its content. There's fragmentation as well of the nucleus and dissolution, right? We're going to see what that looks like. Breakdown of plasma membrane happens, and there's leakage of the content of the cell. There's the organella membranes as well. That's, for example, the mitochondrion can break up within the cytoplasm, right? And then you can also have the nucleus itself open up and then leak its content, out. Then myelin figures appear. There's leakage and enzymatic digestion of cellular content. Once that happens, in fact, at the appearance of myelin figures, you are certain that necrosis is already in place. Now, for apoptosis, very, very important, the formation of apoptotic bodies, that's fragments of nucleus and cytoplasm clumping together, already gives us an indication that apoptosis has started. There is a very detailed process for apoptosis coming to play, and we're going to see that shortly. Now, there's also nuclear, that's chromatin condenses within the nucleus, leading to apoptosis. Now, how do we differentiate between necrosis and apoptosis, right? For example, for cell size, under necrosis, there's enlargement of the cell size. Under apoptosis, the cell size becomes smaller and shrinks. For the nucleus, there is fragmentation and dissolution, right? Fragmentation. So pycnosis, chyorexis, and chyolysis are the processes I described earlier. where we talked about shrinkage, fragmentation, and dissolution, right? That's the 3 steps: leakage, fragmentation, and dissolution. Now, while dissolution happens in necrosis, in apoptosis, the nucleus fragments, right? So there are small fragments of the nucleus found within the end stage. And then for the plasma membrane, it's usually disrupted in necrosis. It breaks up and the content leaks out. For apoptosis, it's usually intact, right? Or even though it's altered in structure, but it's usually intact. And you just find, like an empty pit. Or if it's a large apoptotic body, right, you just find a shrinkage and a kind of a kind of vacuum, right, in the area where that organ used to be. And then for cellular content, there's enzymatic digestion in necrosis, which usually leaks out of the cell. And then there is the formation of apoptotic bodies in apoptosis. For inflammation, is frequent in necrosis. In apoptosis, the process of cell death is contained within the cell itself. In terms of physiologic or pathologic, necrosis is always pathologic, but apoptosis is often physiologic, right? It's a way that the body eliminates damaged cells. This mechanism helps bring what happens at what stage together, This you can easily study on your own. It's just differentiation, just as I've described it from the previous slide. The same thing here, pictographically reticulum and mitochondrion happens, but you must see here that the rough endoplasmic reticulum has ribosomes. Still attached to the endoplasmic reticulum. At that point, function is still maintained. Right? There's clumping of chromatin, but no dissolution of the nucleus, right? There's swelling of mitochondrion, but no breakage of the mitochondrion, right? There's blebbing of the in reversible cell injury. So once the stress is removed, the cell can recover and regain its function, right? But if that stress is not removed, then the process of death is initiated, and then you can have swelling of the endoplasmic reticulum and the loss of its ribosome. And then, of course, the swollen mitochondrion becomes darker and also breaks up, right? Okay, so that's swollen mitochondria with amorphous densities. And then you also have nuclear condensation, right? All of the nuclear material begins to condense into an irresoluble dissolution, right? And then you have the appearance of myelin figures, like I mentioned earlier on. And then, of course, the final stage of necrosis, which is death. So now let's quickly talk about apoptosis and why it's important. It's a regulated mechanism of cell death and helps our body eliminate unwanted and irregular reaction. For example, remember when we mentioned earlier on, we said that there is no adjacent inflammation with apoptosis. Meanwhile, with necrosis, because it's mainly a pathological process, there is adjacent inflammation always happening. Apoptosis is characterized by enzymatic degradation of proteins and DNA initiated by caspases and the recognition and removal of dead cells by phagocytes. A useful process in maintaining function, right? And apoptosis way and the death receptor pathway, survival signals, right? For example, once there's DNA damage as well, an accumulation of misfolded proteins, then that process is triggered, right? It's associated with leakage of pro-apoptotic proteins from the mitochondrial membrane into the cytoplasm, where they trigger the caspase activation. Once caspase is activated, right, that leads to the whole enzymatic actions and breakdown that leads to the formation of the apoptotic bodies, right? Now, this is inhibited by the anti-apoptotic members of the PCL family, which are induced by so if survival signals come back again, of course, that will inhibit the apoptotic bodies. Will inhibit the caspase activation, right, leading to the apoptotic bodies won't be formed, right? But that's only in the presence of survival. Oluwatobiloba, you have a question?
Yes. Sir, please,
Do you have a question?
Yes.
Yes, go ahead.
Please, could you start from the place where you were talking about apoptosis? You lost me because of your time.
What? Chat box. Please put your question in the chat box. I'll attend to it as soon as I say it. And then the death receptor pathway, as soon as I said. The death receptor pathway is responsible for elimination of self-reactive lymphocytes. And when damage is caused by cytotoxic T lymphocytes, it is initiated by the engagement of the death receptors, members of the TNF family, and by ligands on adjacent cells. This death receptor pathway is initiated by the cell itself. The death receptor pathway is initiated by the cell itself, right? And it's an important part of growth for most organisms, most living organisms. It's an important part of growth. The cell can initiate its own death process, leading to the cells being cleared and the nutrients that it is broken down into being reused by other cells nearby. I have not seen any questions from Oluwatobiloba. So let's take one more quiz just to be certain that everybody is following. Are we ready? Where's my quiz? All right, you should see the quiz on your screen now. Let's quickly get to work. 2 minutes. Let's get to work. 2 minutes. All right. I'm sure you all can see the poll result now and compare that to your answer. Most of us did quite well on question number 1. And a few of us did well on question number 2 as well. All right. So with that, let's continue with our session again. Let's quickly talk about inflammation and repair. What's really? Oh, sorry. Oluwatobiloba, I just saw your question again. I just saw it, really. You said I should explain the mechanism of apoptosis again. I couldn't hear me the first time. Don't worry, I'm going to make available the recording, right? So you can go through both the recording and the slides, so you can go through these again. Half stats, yes, go ahead. Half stats, you can unmute and talk. You can either unmute and talk or send a message on the. You can unmute and talk. Saw another hand raised just now. You couldn't see the answer of the quiz. Don't worry, to be sent to you. The questions and the answers, everything will be sent to you. No, it won't be the same in recording because the primary line is from me. So what I'm saying is what is the challenge is when it's being downloaded from your side. That's where the break-in happens. But don't worry, I'm sending you the notes, the recording. I have 2 years of recording for these same sessions as well. I can share those links with you as well. So let's quickly, because of our time, and because I don't want to bore you to death, right? Let's quickly tackle inflammation and repair. So we see what we have to work with. So inflammation and repair. Inflammation usually has a couple of signs, about 5 signs, from which we usually say there's inflammation happening. Redness due to increased blood flow and vasodilation, heat or fever due to increased blood flow, swelling from inflammatory edema, pain from swelling, and presence of inflammatory mediators, mostly cells, and pain transmitters as well. And then there's, and then loss of function due to main and structural necrosis, right? Those are the 5 signs of inflammation. Now, inflammation can be acute, means it can be sudden and resolve as soon as, the inflammatory process is resolved, or it can be chronic, meaning that it recurs chronic and, with several cycles of exacerbation and resolution, right? So it can be acute. You have a series of reactions of vascularized tissue to injury. It also helps in defending against foreign substances. So acute inflammation can happen when your body is trying to get rid of bacteria invading your body, right? When your body is trying to dispose of dying or dead tissue, when your body is trying to immobilize an injured area or compartmentalize an area that has been injured. So give me a minute. It's pouring cats and dogs here. Let me just try and reduce the All right. Okay. So acute inflammation can work for can be helpful in tackling an infection, can be useful in reducing further injury to a part of your body, and can also be a disease process, right? It depends on acute inflammation. It depends on the severity of injury, the patient's immune status, and of course the temperature as well. Now, there are a couple of processes that happen simultaneously during acute inflammation, mainly 4 events: a neurological event, hemodynamic event, cellular event, and a chemical event. So in terms of the neurologic events, there's an initial vasoconstriction that is transitory and reflexive, meaning it's very fast and it may not be observable, and a gradual vasodilation. So there's first vasoconstriction followed by a gradual vasodilation, which is the relaxation of the reflexive spasm and causes bleeding to start. The hemodynamic event that happens is vasodilation leading to the slowing of blood flow, margination of leukocytes. Margination means leukocytes attached to each other in an attempt to block blood loss. Hemostasis, that's the formation of a hemostatic plug, that those large blood cells come together, activated by the so you have like a hemostatic plug, which is mainly both fibrin and other elements within the blood that come to prevent or to cover up the area where blood is being lost. Okay, that's called the hemostatic plug, to prevent further blood loss. And also, of course, there's permeability changes at that site to reduce more blood, pouring into the area where loss is happening. Now, there are cellular events. The hemodynamic is very different from the cellular, right? Cellular event is where you now have the circulating leukocytes, right, activate large cells, and you begin to have margination of those cells as well. Basophils, neutrophils, they begin to migrate to those areas, right? The basophils release anticoagulants in the initial phase, trying to ensure that if there's debris or microorganisms that are trapped within the injury, there is enough blood loss to carry out the pathogen before the hemostatic plug is formed and seals up the area and prevents further blood loss, right? There are neutrophils as well that are released in the area, mainly phagocytes, okay? And the phagocytes essentially are coming in, they are picking up microorganisms that are remaining there. They are trying to reshape the hemostatic plug to ensure that a new layer of fibrin is laid once there's no longer bleeding. Then there are monocytes and macrophages, which arrive in the last phase to clean up the debris, broken bits of bone, scraggly tissue, and all of that. And then there's a chemical event which helps promote the perception of pain and all that you usually feel when there is an injury. Histamines, for example, are formed, bradykinins are released, prostaglandins are also, they are transformed into all of the other forms that help to promote both pain and healing. So usually for acute inflammation, there's immediate vasoconstriction once the injury happens. Within the next hour, there's gradual vasodilation of blood vessels within the area. The hemostatic plug becomes formed within the hour. You have mast cell degranulation. You have margination of white blood cells. large-scale neutrophil response also happens. And then much later, you have hemoconcentration from edema, ischemia, interaction with chemical mediators, emigration of the larger white blood cells, and initiation of the complement system. You, of course, remember the complement system, right? And of course, later you'll begin to find the formation of abscesses, ulcers, cellulitis, and pseudomembranous inflammation. These are some of the... Now, for chronic inflammation, right, there is recurrent inflammation prior to completion of repair or resolution. So the initial inflammation does not complete, right? Before it is resolved, there's exacerbation again, and then another resolution, and then inflammation again, on and on like that, right? This leads to something called chronic inflammation, and it's very important in disease formation, especially where you have, it's an important process in the formation of tuberculosis, right? Caseation, there's something called caseation in tuberculosis, and it's a very, very hard, process to treat. It's a point where there's a cheese-like formation that hides the bacteria deep within dead cells and pus, right? And it's very hard to treat. But every time the mycobacteria comes up again, a new inflammatory process begins, right? So that leads to it's usually is a source of recurrence of mycobacterial infection. So it's very important in our treatment of tuberculosis, right? And the cellular aspect is very important. Macrophages predominate in chronic inflammation. If you remember, these are the last guys that we said, come to the site of injury, right? Macrophages, those big cells, the monocytes, giant cells, fibroblasts, and lymphocytes. These are involved in, reshaping new tissue that is being laid to heal. Every time it gets injured again, there's new tissue laid. The fibroblasts are trying to strengthen it, shape it, so it doesn't become too bogus for or non-functional for the area where the new tissue is laid. So all of this happens. And then, of course, there is CD8 plus T killer cells and CD4 plus T killer cells as well that participate in delayed hypersensitivity, right? This leads to hypertrophic scarring, buildup of type 1 collagen in chronic inflammation or healing. You may have seen this in some patients as well who probably have undergone, who maybe have had an injury that took very long to heal. There is a lot of scar tissue. Sometimes it's not even as elastic as, the surrounding skin that builds up in that area. Now that's chronic inflammation. Now there's a special type that, like I mentioned, that we are very interested in, granulomatous inflammation. A granuloma is an abnormal structure built from at least two activated macrophages, right, adhering to one another, and they may sometimes be called epithelioid cells. Granulomas may be formed with caseation, which is typical in fungal infections and tuberculosis. And in this case, where you find caseation, is the infection is very hard to treat. It may be formed with suppuration, that's granulomas with suppuration, that's pus, and it's typical in infections that involve the lymph nodes, like brucellosis and plague, right? And it could be also found around foreign bodies, people who have maybe splinters or bullet fragments in their body, sutures that have been covered up by their wound, or mucus plugs, for example, in cystic fibrosis, right? All of these are an important type of inflammation because it makes healing or treating the chronic inflammation very difficult. Now, inflammation resolves when the non-structural cells are lost after inflammation or damaged cells have been regenerated or repaired by fibrous tissue. Labile cells or continuous replicators, right? These are the type of cells that you have, and the kind of healing that you usually have, following. For labile cells and continuous replicators like the skin, gut, and hematopoietic cells. And then you have for stable cells that have little proliferation without injury, but can divide rapidly if necessary. For example, the liver or renal parenchymal tissue, right? This happens with permanent cells and they heal by scarring. So for labile cells, you usually have regeneration of the tissue, right, to end inflammation process. But for stable cells, they usually heal by scarring. For example, the brain, the heart. If there is myocardial infarction and injury to the heart, it ends by scarring. What's going on? Just give me a minute. Okay, so let's talk about tissue repair. Tissue repair can come about in two stages. First, you have the fibrous repair. That's where fibrin is laid on to enable return of function and healing. And then there's maturation and remodeling. So during fibroplasia or fibrous repair, there's formation of granulation tissue. Granulation just means repair tissue, okay, or growth tissue. Those are the early kind of, for example, if there's a fire burn or a hot water scalding, right? The lighter skin you find under, your skin when the debris has been removed, right? It's usually covered by a thinner layer of skin initially, which is fibrin. And then when that becomes matured, you find that that's part of the skin is remodeled, right? The scar matures and is remodeled due to stress and strain. And even though it's more fragile than the tissue it replaces, but there is return of function, right? You're not easily hurt at that place again. There is healing and then a new layer of skin, right? Now, the reason why we're looking at tissue repair is because, importantly, after surgery, right, a wound is created during surgery, and there are different ways it can heal. Now, when it is healing, it can heal by primary intention. That means the surgeon has neatly arranged for the edges to be well opposed, right? And so no big scar is left. That's one way to think about it. The other way it can heal is secondary intention, where the person is not either by plan or by negligence, the skin is not properly placed in a way that enables the edges to close without any scar, right? At this point, granulation tissue is formed from bottom up since the edges are not properly opposed, and this leaves a big scar. The factors responsible for wound healing are growth factors like the platelet-derived growth factor, epidermal growth factor, fibroblast growth factor, transforming growth factor, TGF, and TNF, and cachectin. These are important for growth and healing. And while I'm going to send this to you, so we're not going to take this self-assessment right now, but I wanted to point something out before we move on. First is that in a process of inflammation, right, there are both chemical and cellular events. But the chemical events control both the cellular and hemodynamic and the neurological events that happen. So the chemical events are very important. Remember, we said these chemicals are important for inflammation. Histamines, bradykinases, and prostaglandins, right? Bradykinases promote pain. Prostaglandins are important in the nociception of pain. Histamines also promote the activities of the prostaglandins. Now we're going to see how all of this comes together when we are treating patients for pain, right? So let's quickly look at anti-inflammatory drugs. This entire lecture builds together to help you see the basis of drug targeting or substrate targeting, right? Essentially, pain relief happens because we have a fair understanding of the inflammatory process that happens. So we have two classes of pain relievers here, the NSAIDs and the SAIDs. That's the one we're going to, anti-inflammatory drugs that we're going to talk about today. NSAIDs and SAIDs. The SAIDs are the steroidal anti-inflammatory drugs, while the NSAIDs are the non-steroidal anti-inflammatory drugs. Now, let's first talk about the non-steroidal before we go to the steroidal. The non-steroidal anti-inflammatory drugs are divided into two: the non-selective NSAIDs and the COX-2 selective NSAIDs. Now, we've talked about inflammation. We've talked about its signs. We've talked about the mediators of inflammation. You remember, right? We said the main actors are prostaglandins. Their activities are promoted by bradykinin and histamine. And more so in the brain, serotonin also modulates the perception of pain. And a number of other chemical mediators are also present in the body, you know, supporting prostaglandins as well. Now, these are some of the roles of some of the prostaglandins. We will not dwell on that. I will leave you to read that up, right? Now, the important one are the cyclooxygenases. These exist in tissue as constitutive isoform 1, COX-1, right? The cyclooxygenase 1 are important in the mucus production, in the production of the mucus that lines our stomach, that lines the lumen of the stomach, preventing adverse effect of the acid in our stomach from affecting the wall of the stomach. Okay, that is what the COX-1 does. Even though it's a cyclooxygenase, it is constitutive and protective for us as human beings. Meanwhile, at the site of inflammation, right, we have cytokines stimulating the induction of the second isoform, which is cyclooxygenase 2, which is important in the formation or in the transmission of pain, right? And inhibition of this cyclooxygenase 2 is thought to be the bedrock of the anti-inflammatory activity of NSAIDs. Now, inhibition of COX-1 is responsible for all the GI activity toxicities that we have seen with the anti-inflammatory drugs. Okay. Now, like I said, we have some that are selective for COX-2, which we are going to see later. But in the meantime, let's see the non-selective COX inhibitors. We have about 8 classes. We have the salicylates. Salicylates can be acetylated, for example, the acetyl salicylic acid aspirin, and can be non-acetylated, for example, diflunisal and salicylamide. Both are non-acetylated salicylates, right? There's also the pyrazolone derivatives, for example, phenylbutazone and metamizole, which is analgin, and it's both have been banned, you know, from clinical use. There is also the naphthylalanine derivatives, for example, nabumetone, which is It's called a weak selective, it's called a weak selector for COX-2. Then there's propionic acid derivatives like ibuprofen and naproxen, which are very commonly used in practice. Then there are the antranilic acid derivatives like mefenamic acid and meclofenamate. There are also the acetic acid derivatives, which have two, like the aryl derivatives, like diclofenac sodium, and then the indole derivatives, like the indomethacin. There's also the enolic. Someone said, I hope we are not rushing through. No, we're not rushing through. Don't worry, we're still going to have enough time to, I'm going to send the lecture note immediately after this lecture so you can read it later today. I'm also going to send the recording or have the recording hosted on a Google Class for you so you can, go through this, at your own pace so that no one is left flustered. Okay. There are also the enolic acids or the oxycam derivatives, like the peroxycam and the meloxicam. Meloxicam is also a weak selector for COX-2 pain reliever, or NSAID is a weak COX-2 NSAID. Then the final one we have here is the dihydropyrrolysine carboxylic acid derivatives, ketorolac. Okay. Next, let's quickly take a few. Okay, so these are selective COX inhibitors, celecoxib, parecoxib, and rofecoxib. Of all these, celecoxib is the only one that is in wide clinical use at this time. Okay. So let's quickly look at their mechanism of action, right? The cyclooxygenases, right? Like we mentioned, COX-1 is constitutively expressed. It's constitutive in the tissues. It's it's called housekeeping function. Prevents yes, Celebrex is celecoxib. You got that right. Housekeeping function prevents the acid in the stomach from adversely affecting the mucosal function of the stomach walls, right? And COX-2 is induced by pro-inflammatory factors, TNF-alpha and IL-1. COX-3 has just been recently developed and its function is still being studied, currently. Now, prostaglandins do not cause pain. What they do is they sensitize nociceptors to stimulation by the 5-HT, bradykinin, capsaicin, and others, right? Now, in the whole cascade, IL-1 released from the activated macrophages, which are those big cells that come later, right? Or from bacteria, toxins from bacteria can also cause the release of IL-1, right? Induces COX-2 in the brain, leading to prostaglandin E production, which leads to thermoregulation, leading to fever. And this is why when NSAIDs inhibit COX-2, they have antipyretic or anti-fever effects. Okay. Now, classical NSAIDs inhibit both COX-1 and 2, which is why we mentioned earlier on that these are non-selective COX inhibitors, okay? Because they inhibit both the constitutive and the non-constitutive cyclooxygenases, right? The inhibition is reversible except with aspirin, right? With the exception of aspirin, right? And they also inhibit the cyclooxygenase 1, which is a COX-1. So that leads to all the side effects that are seen. The GIT, the ulceration, the bronchospasm that is seen, right? All of that is due to inhibiting the constitutive effect of COX-1. Don't worry, we're almost at the end for this particular lecture, but I need to conclude so that you have something to go home with, okay? Now, this is a pictorial representation of everything that happens in the inflammatory process. What I need you to remember is that phospholipids are acted on by the phospholipase A2 to form arachidonic acid. You have seen this cascade already in biochemistry, right? It is the process for inflammatory response. Now, our SAIDs, our steroidal anti-inflammatory drugs, inhibit at this higher level, while our non-steroidal anti-inflammatory drugs inhibit cyclooxygenase, which is required to convert arachidonic acid to cyclic endoperoxidases. Okay? Now, when cyclic endoperoxidases are formed, they naturally break down to form prostaglandins and thromboxane. These are the substrates that promotes inflammation, the swelling you feel, the pain experience, and the fever or thermal dysregulation that happens, okay? Meanwhile, on the thromboxane side, there's vasoconstriction and increasing platelet aggregation. So this is a simple story that helps us see why we use the drugs that we use and the combinations we use, okay? Very, very key. The mechanism of action, this just removes the earlier part, removes the initial part, showing the SAIDs, glucocorticosteroids, right? And just only shows, oh, sorry. It shows the glucocorticosteroids, right? The phospholipase. So this is the early action with the steroidal anti-inflammatory drugs. But these steroidal anti-inflammatory drugs also end up causing a lot of hormonal changes, which is why, so a lot of side effects come up from using steroidal anti-inflammatory drugs. That's why they're not popular for use in terms of pain relief. They are often used in where there is severe inflammation, but not with pain relief, okay? For pain relief, the non-steroidal that attacks the cyclooxygenase and prevents it from converting arachidonic acid to prostaglandins is the most effective with the least number of side effects, okay? And that's why it is being used, okay? The pharmacological effects of NSAIDs: anti-inflammatory, reduces inflammation, reduces swelling, reduces the pain, analgesia, reduces pain. Antipyretic, reduces fever, so it improves thermoregulation. Antiplatelet, basically the aspirins, okay? And then it is used in newborns in the closure of the ductus arteriosus, right? Which is one of the uses of NSAIDs in newborn. It is a specialist procedure and is not commonly, commonly used. So it solves pain, solves fever, and of course, that gives rise to all the clinical uses for NSAIDs that we have for pain, for fever, arthritis, for prevention of myocardial infection, myocardial infarction, stroke, and reinfarction. We use aspirin basically for number 6. For the unclosure of the ductus arteriosus, also aspirin. Like I said, because of the toxicity of aspirin in children, it is only left for specialist use. There's also dysmenorrhea. Ibuprofen is used, and then of course, more commonly here in Nigeria because of cost, piroxicam, commonly called Feldin or Felvin or Felenitin, right, is used for dysmenorrhea as well. The side effects are classical. We have explained everything that causes the side effect, so it should be at the top of your fingers. GIT disturbance, you know why? Because of the blocking of the COX-1 constitutive, part of the GI. CNS disturbances, COX-2 inhibition as well. In the blood, the COX-2 inhibition, homeostasis as well, hypersensitivity reactions. This is more related to cell reactions. Ray's syndrome or bronchospasm exposure in people who have asthma. There's also disorders of cartilage or subchondral tissue in people with sometimes happens with people with arthritis who are on long-term and high-dose NSAIDs. Liver, again, there can be liver toxicity, asthmatic exacerbations, kidney injury, acute kidney injury. They can also lead to kidney failure. Then on the heart as well, it can lead to arterial hypertension and cardiac insufficiency. These I expect that you have at the top of your fingers, since we already have an understanding of why these side effects form, right? Of course, NSAIDs are contraindicated in pregnancy, patients with bleeding irregularities, hemophilia, hypersensitivity reactions, viral infections in children, and people with peptic ulcer. Of course, you know why. There are a lot of drug reactions for the medicines. Now, I'm going to send this to you. Please ensure you pay attention to each of the classes and the notes on them. For selective COX-2, we've talked about, I think we talked about celecoxib, which remains in clinical use. They have no clinical effect on platelet aggregation, even though it's been shown that they sometimes inhibit COX-1, but not appreciably or clinically, right? So those are COX-2 inhibitors, right? That's a mechanism of action. The last class is the steroidal anti-inflammatory drugs. Then the longer acting one. Sorry, you couldn't hear me because of the network. It was seriously degraded. That was why you couldn't hear me. Sorry about that again. So just to round up, steroidal anti-inflammatory drugs have a lot of side effects, and it is one of the reasons why they are mainly reserved for serious inflammation, right? And other disease states where there are no where there are no other medicines that's, or for example, in asthma, for example, severe allergy reactions, these are chronic inflammatory conditions, right? So that is why they are mainly used in that. Now they have a lot of side effects that are sometimes thought to be that these side effects from SAIDs, that's the steroidal anti-inflammatory drugs, can affect a person's quality of life. So it's important that when they are being dosed, we ensure that they are dosed at their minimal or the lowest effective doses, not the highest effective dose, the lowest effective dose. So most times when you stabilize a patient on steroidal anti-inflammatory drugs, you need to begin to taper down the dose in order to prevent injury to the patient. With that, we come to the end of today's lecture. And so I want to say thank you for attending this lecture. I hope it's been interesting. Let me take questions if you have any. Next 5 minutes, if you have questions, let me have your questions. If you have questions, please let me know. Yes, as soon as the recording is ready, I will send it across with the notes like I have said. I'm going to send my, okay, so what I think what works probably is to onboard everyone into the Google Classroom so that you can, it's very easy to ask questions in the Google Classroom. You drop it in the public fora and then I can respond there as well. So I'll send the link to the Google Classroom. That might be more tidy really, since you all have your email addresses. I'll send the link to the Google Classroom, onboard everyone there, and then put both the notes and the recording there. And then if you have any questions, you can easily ask in the Google Classroom. I hope that's fair. So that you don't have to wait for anybody to send it to your email or send it to your WhatsApp. You can download it by yourself. Okay. All right. So with that, we've come to the end of today's class. I haven't had any questions from anyone. We're going to have a 1-hour tutorial tomorrow morning for 8 o'clock. We'll start by 8:15. I'll send the Zoom link right away to your class rep who will share to the class. Okay. Best regards, everyone. Have a pleasant evening. Bye.